Hello, everyone. Welcome to today's healthcare webinar, brought to you by Jones Roth CPAs and business advisors. I have the privilege of speaking with you today about best practices in patient collections. This is an excellent opportunity to get expert advice, and we'll have a brief Q&A at the end of our presentation. Before we get started, I want to take the opportunity to introduce to you Jones Roth CPAs and business advisors. Our practice success plans at Jones Roth provides value to owners and administrators throughout the year by maximizing operational and financial performance. Jones Roth also supports the personal success of practice owners through integrated tax, retirement, and financial management planning. We'd all like to thank our generous sponsors, Watkinson, Laird, and Rubenstein. They provide a broad range of legal services to healthcare practices. With expert knowledge of the regulatory environment, their healthcare attorneys can help navigate through the challenges of operating a healthcare practice. My name is Elizabeth Woodcock. I am a speaker, author, and trainer, and have been fortunate enough to be in practice management for now almost 30 years. However, the beginning of my experience, which still informs me today, was at a traditional billing office where, interestingly enough, we only had 2 employees out of 200 who specialized in patient collections because all they did all day long was write things off. We didn't care because we were making too much money on the insurance side. How times have changed. And so I'm here today to talk to you about best practices in patient collections. Now, what's interesting is from a current state perspective is we have quite a conundrum. Employer premiums and deductibles have risen significantly, and importantly, they have gone up much faster than wages now for about the last decade. This left us in quite a mind because even though we complain about United Healthcare, Medicaid, and all of our other payers, indeed, actually, the newest payer in the market, which of course is our patients, is definitely the most challenging. Now, part of that has to do with collections, which is what we usually focus on. But at the end of the day, we know that a dollar saved is a dollar earned. And so part of the strategy I want you to think about as well in current state is how much you spend to collect from patients. Indeed, collecting from patients costs twice as much as it does to collect the same dollar from an insurance company. It adds up to about $8,000 per provider per year, just in statements alone. And so if we can think about how we can soften those costs to really save money, that actually is, well, it's not as good as collecting on those accounts because we want to make sure that we have a history of that patient having that financial responsibility, but it certainly means a lot to our bottom line. Now, one of the interesting things that has really changed in the last year is the Families First Coronavirus Response Act, which of course was passed into law right after the pandemic began, really had actually a fairly significant impact on our ability to collect from patients, even today. And the reason I say that is the government actually gathered together Blue Cross Blue Shield, United, Cigna, Humana, all the other major commercial payers, and said, you know what, we as Medicare are going to go ahead and not impose any sort of cost sharing. So that's, co-payments, co-insurance, et cetera. We want you to do the same. And so indeed, everybody got together last spring, all of those insurance companies, and said, you don't have to worry about any sort of cost sharing related to the pandemic. But I don't know about you, like as a patient myself, I was kind of getting used to this no copayment thing. And so a year later, actually, the insurance companies started to roll back on those waived cost sharing. And that's left us in the medical practice environment in a little bit of a bind because our patients certainly got used to it. Our patients certainly got used to it. Now, at the same time, of course, not only do we have this patient responsibility waiver, but we also know that we changed within weeks all this telemedicine and contactless registration. It was all awesome. But one of the things that we've really learned is that we kind of have to go back now and make sure that patient collections fits into our operations. When are we collecting co-payments if we're doing telemedicine visits, which maybe last year we didn't have to worry about because it wasn't any big deal. Again, payers were waiving those co-payments, but today they're not. So it really pays for us to kind of rethink this workflow to make sure that we have an opportunity for patient collections to fit in to our current state. So indeed, there's been a lot of forces that have happened in the last 12 to 18 months that have changed what's going on in the market. And it pays for us to take this moment in time to make sure we have our revenue cycle management processes aligned accordingly with today's environment. And so we're going to talk about how that fits in to our patient collection strategy in 2021 and moving forward.
So what do we do? I'm going to give you a really hopefully good plethora of best practices. And what I would encourage you to do is to select three, well, maybe four or five, but I know all of you are coming from different specialties, radiology, family medicine, multi-specialty practices. And so these are going to be really different strategies or different tactics that your practice may or may not feel like they can effectively implement. So go ahead and select three or four that you can feel like you can commit to at least trying to either improve the probability of collections or to actually decrease the cost of collections. So first, let's don't be lame. And I kind of mean this a little bit jokingly, but we really can't run a poor practices of operations. We want to make sure that we operate a good practice, that we have the ability to be able to collect that 100, 150, $200 that we may not have been able to collect if we were making our patient wait for months to get in to see us, even for an appointment, and then hours once they got there. And I think this is a really nice place to start collaborating between revenue cycle or financial services and our operational team to really be able to focus on a singular outcome of improving the patient's financial health. And part of improving the patient's financial health is really giving the patient a reason to want to pay us. So we want to make sure we operate a good practice. The second thing is let's make sure we define what we will collect. I think an absolute baseline is co-payments, deposits, and balances. Let me unpack those. Co-payments, of course, are those, it used to be 10 or $20. Now they're 40, 50, 60, $75 co-payments. Or if you're with an emergency medicine practice, it's 4 to 500. These are really must do because as we know, the allowable for at least some of our payers for a 99211 or a 99212 is actually matched by the copayment. We also want to make sure that we have a deposit in place for what I like to call our full pay patients. Our full pay patients are those patients who have no insurance. We want to make sure we have some sort of deposit level for those patients. Maybe it's $10 or $20, or it could be as high as $100 or $250. We want to make sure we collect those at the point of service. And then lastly, a absolute must do is a balance. And I say that because there's really a mindset associated with balances. Let's think about this, right? If a patient has a balance with your practice, they have a statement, maybe even they've tucked it in their pocket or they saw it on the email, and it's this outstanding balance that they have. And indeed, they're carrying this around. And if you don't ask them for it, the patient then emotionally disconnects with payment because, I mean, they've been in your business, they've been walked through your doors, and you didn't even talk to them about it. So I think these three are the can't live withouts. And then we go below the line here, we start to think about how we're going to collect coinsurance, unmet deductible, non-covered services, and lastly, pre-service payments. And I put these kind of below the line because they do require calculation of the allowable. And then of course, when we talk about coinsurance, for example, that's one step further where then we're calculating 20%, for example, of that number after we confer with the payer to see if the patient has met their deductible, perhaps, etc. So there's some complicated steps. They're doable, but you have to have the workflow to support them. Now, importantly, I believe for many years it was a myth for me. At least I know a lot of people told me, perhaps they've told you, well, Elizabeth, I mean, we really can't collect anything except for copays. And so I wanted to provide you this material from the Centers for Medicare and Medicaid Services that actually indicates in writing from Medicare, well, from CMS talking about Medicare, that you do have a right to collect. You just simply have to do it for everyone, right? So I can't just go to a Medicare patient and say, give me the coinsurance or give me your unmet deductible. I have to do it for everyone. And this, of course, makes sense because CMS is just saying, like, we don't want to be kind of pigeonholed here and discriminated against by being the only group of patients who was asked this. So I wanted to make sure I gave you this. I've given you the URL and everything, so you can take a look at this if you do want to go, if you will, below the line. Now, some of this is simply focusing on the basics. We want to make sure that we use the patient's name, that we look the patient in the eye. This could be from telemedicine as well, and that we actually demonstrate that we expect payment. This is easier, of course, if you're face to face with someone, but actually going ahead and writing out the receipt as you are asking the question. So we want to make sure that we work with our teams on these basics because oftentimes we hire teams for our reception area. We hire medical assistants who may be involved, for example, in collecting co-payments, particularly for telemedicine visits, because they're often the ones who quote unquote room the patient in the Zoom or go to my webinar or whatever video platform that you're using for your telemedicine visits. So we want to make sure that we train our team on these basics. And while they are basics, they're important. Using the patient's name, looking them in their eye, and demonstrating that you really truly expect payment. Speaking of that, we don't want to have our wayfinding or our signage within our reception areas, which they should be called, by the way. The mere fact that we use the term quote unquote waiting room. I mean, that's pretty embarrassing because basically we've codified waiting. We're so sure you're going to have to wait. We've even named a room as such. So let's change that signage, maybe make it a lobby, a reception area, and then think about the signage that you actually have on the walls. First of all, a great tip is to take everything down that's been taped up, and especially if it has misspelled words. I pretty much can always walk into a practice and find a misspelled word. Sometimes I think it's because we kind of make these signs up during a quick staff meeting and somebody goes and types them on a computer. We expect you to pay your copayment at the time of service. Actually, that's not true. Your insurance company requires you to pay your copayment at the time of service. And I think it's important to convey that to our patients because, if you will, those are the facts. So let's make sure we go back to what I talked about with regard to a deposit, that these full pay patients, remember that's my term for self pay, and it's true. Well, for some reason, self pay has become synonymous with no pay. So I like to go back to the facts. This is a full pay patient. And I think it's a good idea to really consider your community when it comes to establishing these deposits. It may be as low as $10. You may have a community and a specialty that can support $250, $300. The key here is to choose that level, put it in writing, and make sure you apply it consistently. We want to make sure that we think about perhaps bifurcating our deposits between new patients and established patients. You might ask, why? Well, when you think about that, we don't have any history of payment for new patients. This is like the first time out of the bat they would have been at our practice. And so, because we don't have that history, I think we deserve to have that potential for a higher level of a deposit. On the established patient side, that $50 or whatever you may set it, again, make sure you apply it consistently. We've got that history, so we feel a little bit more comfortable. Plus, when you think about it, a 99204, for example, it's about a 30% higher reimbursement rate than a 99214. So, this is the way our coding and reimbursement system works as well. Okay, let's make sure we get that script down. I don't want to hear, would you like to pay? Indeed, how will you be paying today, Miss Jones? And then go ahead and think about this strategy. I love this. I learned this from an amazing general surgery practice. They ask first for the copayment. Doing it in those words we described before on the sign, your insurance company requires a copayment of whatever that may be. Fill in the blank. Will you be paying with cash, check, or credit card? And then importantly, wait for the card. Then our next step is, oh my, the computer tells me that you have a small balance of fill in the blank. What are we doing there? We're giving a pause. We have the payment mechanism in our hand. This isn't about us, it's about the computer. And believe you me, you always have a small balance, whether it's $17 or $1,700. So can we go ahead and run your card to take care of that balance? So it's little tiny techniques. Now, you will see here that while I'm talking about this script, I'm in no way saying don't see the patient if they can't pay, deny care if they can't pay. That is definitely not the recommendation. What we're talking about here is being able to ask, making sure that we ask with confidence and with tools in terms of how we ask for payment. Now, it's up to you to kind of think about and create a protocol or a policy. You certainly want to confer with your malpractice attorney about not seeing patients. So that's a whole nother dialogue. What I want to go back down to is this action plan related to the script. Let's go ahead and make sure it's a compelling one. And then perhaps the two most important words in patient collections. Once you ask the question, shut up. You just need to stop talking altogether. And the reason we want to say that is because we have a tendency in medical practices to, well, create some pretty ludicrous payment plans. We might have a, 64-year-old with a $78,000 spine surgery, and somehow we talk ourselves into the $5 payment plan that we're offering them. And obviously, that's an extreme example, but research has actually shown that our patients will give more favorable terms than us. Americans love a discount. And when you think about it, every time you see an insured patient, you actually are offering a discount. Yeah, we call it something kind of a fancy from a billing and collections perspective. It's called a contractual adjustment. That's exactly what it is. Let's go back to the early years of the 20th century, and somehow physicians got kind of, I don't want to say their arms twisted to accept insurance. I don't know how the dentist did it, but they were able to kind of get out of that whole scenario altogether. But as medical practices, we basically offer discounts in the form of contractual adjustments to insured patients in exchange for having patients come to us as preferred providers. So it's like an exchange, right? It was a negotiation. We sometimes forget about that we went into this willingly, but we did go into it willingly. And that contractual adjustment is indeed a discount we are offering to our patients. So you can see the sample financial agreement, I've actually called it that. And in fact, this is a really good thing to talk to your team about because a lot of times patients will ask for discounts. And your team can be able, if they're knowledgeable, to respond with, well, gosh, you're a Medicare patient or you're a non-ad patient or Blue Cross Blue Shield or whatever it may is, and we actually do offer you a discount. It is a contractual adjustment. We want to make sure we engage the right people. And I think this is particularly important today during the staffing crisis that we're in. And maybe some of this is well deserved from our perspective in terms of really needing a change. And why is that? We have a tendency to use terms like the front desk when we talk about a team of people. Well, a desk is like a furniture, it's an object, it's not a group of people. So we've really got to step back and make sure that we really, really treat our teams with respect. Got to make sure we actually hire the right people as well. And I say that because we've become pretty obsessed with ourselves. Let's say we're a neurology practice and I don't know, we use Athena as our practice management system. Well, we go down the path of creating these job advertisements where gosh, we will only review resumes from neurology practices and only people with experience with Athena. And honestly, I mean, I know neurology is complex and I know Athena's complex too, but they pale in comparison with teaching someone how to smile. Hire for fit, not function. And it will allow you to really, I think, kind of gain some more insight into who we need for these positions. And I'm talking, as you can see, based on my quote unquote directors, about that reception area and that wonderful team that we have to greet, to receive our patients, because they are truly our directors of moments of truth. They are directors of our time of service collections as well. And that's important for us to recognize. Now, we can go down the line with other staff members, like I like to refer to our schedulers as directors of business development. So, really dig deep into who you have working with you and make sure that your team has the respect they deserve. I do believe that that front office team has the most important and I would argue the most challenging role in a medical practice. So maybe it's due time to really think about who those team members are and making sure we engage and really focus on retaining them. Now we've got to make sure, speaking of fit, that we do have some basic skills, particularly if we go below the line, as we talked about with point of service collections. We have to have team members who know how to, for example, take 20% of a number. And so, what I like to do is think about involving these questions when a candidate is applying for a job. And you can do this with, gosh, any type of position. And we know this is well, I would argue a really good idea, because the fact is that the vast majority of people, the last I read was 70%, provide inaccurate CVs or resumes. So we need to kind of have that double check, because a 30-minute interview is really, really not doing it any longer. This collections, well, sometimes has some negative connotation, which is why I like to call it patient financial health, so that we don't use that term patient collections any longer. But when we talk about the patient's financial health, it's important to recognize that it is really everyone's job, not just those who are in the quote unquote central business office. Now, let's make sure that we avoid forgetting about balances. And that does include thinking or having a mindset that we can only collect on quote unquote past due balances when they're 90 days old or 180 days old. Indeed, a balance is a balance. We should actually take the word past due or that reference completely out of our vernacular. And then we need to start thinking about, okay, how are we going to collect on balances? And I would argue that we can think about not just having it at the point of service, but think about during scheduling, for example, when patients call. Again, we don't have to not schedule an appointment or not provide information. But if we take a moment to ask the patient, oh my gosh, my computer tells me I have a balance. I'd love to go ahead and take care of this. Can we go ahead and transfer you over to our business office? Or, gosh, I'd love to help you with this. Can we go ahead and take a credit card down for part or all of that balance? So, to really think about how to integrate that as part of our workflow. And, w- you know, this is not just us. When you think about any sort of, retailer or anybody like this, we're kind of scared of this, but what other aspect outside of healthcare do we ever walk around and get a product or service for free and then have to pay for it 60, 90, 100 days down the line? Nobody, nobody. So again, we're not talking about threatening or denying, but we are talking about asking, making sure that our team knows how to collect bad debt. I had this happen myself where I was working behind a team member, and all of a sudden the screen started flashing as he was checking in a patient. Boom, boom, boom. And I thought to myself, oh, let me just kind of poke around and see what that is. And you can see what the screen said. And so afterwards, I said, "Oh, you know what, Joe? Tell me a little bit about how you dealt with that screen flashing, because, I saw that happening in the middle of registering and checking in that patient." And so Joe, and this is a true story, was like, Elizabeth, I mean, gosh, I'm not exactly sure why that screen was flashing, but what I can tell you is that if you go to the top right-hand corner, there's a white X. And if you click on that white X, that flashing screen goes away. Well, I hope some of you are chuckling now, because I certainly was after I actually got out of that face-to-face conversation, thinking that, oh my gosh, Joe needs to be trained on how to identify this past due bad debt that had fallen off the receivables, but was clearly still in the system, needed to be reversed and applied. And unfortunately, Joe didn't even ask the patient about it. And that really puts your central business office in a pickle. Because if they start to go after it, right, the patient is like, I was just there. You didn't even talk to me about this. It just is completely denigrates the ability of that team to collect on the back end. Let's make sure we hold our team accountable. I love this idea of an if not, why not report I got from a cardiology practice. So, we can put all the orientation and training in place. But what this administrator said was, goodness, Elizabeth, I'm still having my team, well, selectively forget to do it, whether it was intentional or not. So she put in play this if not, why not report. And what this does is outline what the team member needs to collect, as you can see, right? It's $10, $123, etc. And if the team member doesn't collect it, they have to record why not. Now, automatically, what you're doing is kind of forcing or requiring that employee to go ahead and think about collections. And then we also, of course, have to recognize that if the team member doesn't collect, just simply giving us a training opportunity to say, well, let's talk through this situation, or here's why you didn't. Let's talk about how we could deal with that. Wow, that bonus. We want to make sure that our team has really that kind of drive to collect. Although I would argue I'm very, very tentative about bonuses. And the reason I say that is I've often found they become expectations. Furthermore, when we talk about patient collections, to me, it's sort of like, I don't know, giving a bonus to your nurse for giving a vaccine shot. Like, really? I mean, should the nurse be incented to do his or her job? So, really think about bonuses, and if you do decide to provide them, perhaps consider a team based bonus instead of an individual one. Now, we want to make sure that our financial clearance is executed effectively. And of course, what this is, we quite often call it an eligibility process, but I want to make sure that it actually is broken down into its various components. We need to make sure we confirm insurance coverage, which is kind of that basic, green light, red light process. Then we want to confirm benefits eligibility, particularly if we're at a practice like a fertility practice, for example. Is the patient not only covered actively, but are they eligible for the benefits that we are about to provide? And then lastly, is there a financial responsibility? And of course, we know that we're going to have to make some changes because of the No Surprises Act that will come into play on January 1st, 2022, that conveys that financial responsibility to the patient. But the big takeaway I want to give you right now is make sure your team not only understands the workflow associated with this process, but where I find we fall short is in handling the exceptions. And I say that because I've seen too many employees who are registering the patient and then, wow, the insurance coverage will come back as denied and they'll register the patient. They'll just keep blowing through. So, especially if you have no required fields or no hard stops, you've got to make sure you have some way to measure that exception handling. Otherwise, you and I both know that all of those become denials. And speaking of that, that's a really great report to hand to your front office team. Denials that are created at the front end by any patient who came through the office. I always encourage practices to make sure that they have that available on a month to month basis for their employees in the front office. And ideally, you actually drive those denials back to the individual employee and report on that. There's a little something about peer pressure that really helps drive those denials down by doing things right on the front end. Garbage in, garbage out. That's my billing and collections mantra. Now, we want to make sure we recognize the new workflow that really all medical practices throughout the US have had to build with regard to virtual care. So, where are we going to integrate patient collections? And honestly, most of the time, collections fits in long before the patient ever sees the doctor. It is on the phone when I schedule. It is when I'm actually doing that pre-reg or rooming process. And then, of course, we have a pretty astute collection of balances after the visit as well. Now, when we have an opportunity to connect with a patient who has maybe either a high balance or it's a patient who is a full pay patient, I don't like to use the term biller or counselor. Particularly, biller will basically send your phone call or your patient off to la la land. They won't even connect with you. Counselor, maybe, but what I like to use the term is financial advocate. And what you could even do is actually flag those accounts and have those patients come or log on if they're a telemedicine or virtual visit 15 minutes early to talk about your bill. And you don't want to actually say that, but that's actually the intention. What you want to do is invite the patient with a quote unquote arrival time of, for an 8 o'clock appointment, a 7:45 arrival. And this just gives you that moment, right? That 10 minutes, because your MA is probably going to step on as well to do that intake or rooming so we can be ready right at 8 or 8:03 or 8:04 for the physician or advanced practice provider. But it gives you that little time window so you can really connect with the patient about their balance. So that's just a really great tip. And again, some of this is nomenclature. I agree. But the words we use, I think we're at a really interesting point just in time, I would say in the US, but maybe even in the world, about really thinking about the words we use and how important they are. So that when we call our front office team the girls, we have to recognize how incredibly demeaning that could be interpreted. You may not have any of that intention, but the interpretation is important. So, again, some of this is, I realize, just a change, maybe not in workflow, but in change in verbiage. But I do think it's a very powerful one. We want to make sure that, because we've really focused thus far on inside the office, kind of having that foot traffic or that telemedicine visit, but we also know that we're very vulnerable when we think about patient collections outside of the office. So, what am I talking about? Of course, I'm talking about the hospital, the dialysis center, the nursing home. Anytime one of my physicians brings back either data or our quote unquote old hospital cards, however you get those charges, you're going to find, of course, that there's patient financial responsibility buried within those response buried within those charges. And so this is where I would argue, kind of have the biggest opportunity. And so what I am seeing practices do is they may even hold those charges for that extra 24 hours and run those through the financial clearance process. And you may say, oh my gosh, Elizabeth, what are you, crazy? We can't hold charges. But when you talk about charges, we have two important issues at hand. We have accuracy and timeliness. And when you think about the return on investment, actually, the highest ROI is going to come from accuracy. So we are really taking that moment to be able to ensure that we avoid that quote unquote trash or garbage that I talked about, and we have clean charges going in. We are thinking and perhaps deploying our credit card on file strategy. And what this does is allow us to collect payment mechanisms in our practice management systems. Some PM systems have this as a component of their software. Others, you can actually purchase it from a third party vendor. And basically, this is what, I don't know, Amazon and pretty much every other retailer does, which is ask us to put the credit card on file. We go ahead and we order the product, like think about what we do with Amazon or any other online retailer, and then we receive the product, I don't know, 5 days, 2 days later, if we have Prime, whatever it is. And so it's really the same notion, except for we're actually holding that credit card then for future transactions. And again, that's exactly what Amazon Prime does and many other retailers. They ask, do you want to hold that credit card on file? So it's a pre-authorized credit card transaction. If you do it, you make sure, of course, at any time you ping that credit card, that if you don't have authorization that is on file, sort of a blanket one that you would do at the beginning, then you go ahead and you get that authorization, and or you send out the receipt as well. So this might be useful for all patients, or you might find yourself as a best use case for payment plans. Now, some patients are uncomfortable with providing their quote unquote private credit card. If that's the case, then you can offer to maintain a payment mechanism on file. Before we set up any sort of payment plan, ask the patient, how much more time do you need? As I mentioned briefly before, our patients actually give us a better opportunity in terms of favorable terms if they are the ones who are defining them. Now, that being said, you also want to make sure that you have, at least in your back pocket, a minimum installment. And in my opinion, that should be $25. And the reason I say that is that's really kind of where we stop making money, right? That's just our cost. And you might say, well, are you crazy? It's $20. But when you actually think about it, you are floating the money, right? You're floating the receivable. And speaking of that, you want to make sure that you create a separate FISC, a financial services category or a payer category within your practice management system for payment plans, because you want to move those off of your patient receivables. And the reason you do is because you have agreed to let that receivable age. And again, you're not collecting any interest, at least most practices don't. So there's a cost associated with that because basically it's a cash flow issue for you. Furthermore, there's all kinds of administrative processes that are behind collecting those installments. So $25 is a really good minimum to think about. Shorten the cycle. So we want to make sure that we have statements at checkout or when they are due. So it's actually at day 0 that we send a statement. Any patient who is in your office that has a balance should receive a statement as they exit. We want to make sure as well that we think about really that kind of tighter time frame than we may have had in the past. I would recommend at most 90 days. And if you are, for example, a referral based specialty like anesthesiology or pathology, and you're not as comfortable with that 90-day cycle process, then what I want you to think about is not extending the time, but extending the touches. And speaking of that, why do we send out statements once a month? We kind of have to pause there and think about that. And I got to tell you, the only answer I've been able to come up with, and I've been at this revenue cycle management thing for quite a while, is that's the way we've always done it. And in fact, this is a big no no in my mind. It's a missed opportunity because how are we paid from a payroll perspective? Most of us are paid via payroll twice monthly. And so we're sending out notices to collect the money once monthly. Well, we have a real opportunity here to change the way we do things, especially as we move to an electronic process, because we're not having to put a stamp on all those costly paper statements. So again, think about maybe not stretching out the time, but increasing the touches. Now, I mentioned this electronic statement. If you have any discomfort with this, I think it's time to throw that out the window and maybe make January 1st, 2020 your moment of implementation. And how might you think about doing it? Oh, we're going green. We don't want any more paper statements because we are environmentally friendly at our practice. Now, this could be a good way to kind of, get some brownie points as well. And honestly, it's the truth. Now, you can see here on this example, and I've actually taken this from an OBGYN practice with their permission, of course. And I think this is a really interesting tactic because what they've done is not only kind of gotten those brownie points for going green, saved money in the meantime, but as you can see here, they've actually said to the patient, so if you don't want to do it, no worries, but we are going to have to charge you this administrative fee for continuing to send paper statements. So, this is a really interesting tactic that may just be that extra little nudge that a patient needs to go electronic with their statements. And speaking of nudges, I do want to pause here and say, I really think there's three, well, let's call them health plans when it comes to our patients. We do have patients as a payer category as I opened up our session today. But within those, that payer category, those three health plans, our first are happies. Our happies are going to be happy to see an electronic statement. They're going to pay. They'll probably put the credit card on file. It'll be easy peasy. But our second group of patients, our health plan, if you will, are our nudgers. And these are the patients who need a little bit of extra something, something in order to collect effectively. That might be, for example, when the patient presents to the front office, your team looks on their person for something to compliment. Miss Woodcock, I mean, what a beautiful suit you have on today. How would you like to take care of your copayment? So the compliment and the question get rolled into one. But then, indeed, we have one less category of patients. And I got to tell you, no matter how hard you try, they have no intention, no willingness, or no ability to actually pay you. And that's where strategies like the one we're talking about here help because at least you're saving the actual cost of billing that patient. Now, before you give up, especially for our nudgers, but even for our no pays, it is an opportunity to perform what I like to call an insurance or a coverage sweep. What this does is many clearinghouses now offer this as part of their solution. If you don't know what I'm talking about, then make sure you make a note to ask your clearinghouse if they do now. Pretty much all the big ones go ahead and offer this as part of their solution. And what this is, hospitals have done it for years and years, is that it is taking that patient's name and whatever other information you have about that patient from a demographics perspective, and it's looking for active coverage. At the very least, you want to make sure that you go into your Medicaid database, or if you're on the border, then multiple databases in terms of different states. And you ask, is that patient, for that full pay patient particularly, do they have Medicaid coverage that might have been active during that date of service? It's exactly what a collection agency does as soon as they get your account. So, performing an insurance sweep, again, this is actually incorporated in many clearinghouses now. And it's really exciting because that discovery of active insurance is a real benefit for your practice. Let's make sure that we have in play with our central business office the ability to manage return mail. So what I mean by this is anytime like the patient will have, if you have a space on the back of your statement, or you ask for this in your electronic statements to print off and to actually have any sort of changes, that might be a change of address, a change of insurance, etc. Make sure you have someone accountable for that workflow in your central business office. You'd be amazed by how many, even large organizations, don't have that. And it's super important to make sure you do. We also want to recognize that we send an invitation. This I learned from a great allergy and immunology practice where they had these envelopes, and you can see they were kind of colored and a little bit odd sized. And the back of the envelope, it said, "You are invited, dot, dot, dot." And when you opened it up, it said to pay your bill. Now, another couple of things you can see, we use an acronym, we use the practice's full address, not a PO box or vice versa. So basically, we're really trying to make this collection notice a little bit distinct. Now, this is where I think, I wouldn't do this for, every single patient, but if you have an internal collections process, you might have gone through those 90 days, you have 4 or 5 electronic statements, you still see a balance, and you're going to go ahead and now send out this quote unquote invitation. It's not going to get my no pays to pay, but it might just be the strategy you need for your nudgers. Our records indicate that the payment due from you is X amount. And goodness gracious, this isn't me, this is our accountant. He, she, or they will simply not allow us to carry this account. Make sure you have the right phone number. Make sure you have a due date. A lot of times we put pay us in 10 days or something like that. And then what is 10 days from what? Make sure we have a due date. And then I like to have a name, a Judy, for example, but make sure nobody named Judy actually works in your practice. Or if you want to use a male name, George would be a good one, or whatever you decide. What we're doing here is we're making sure that when we get a Judy call into our practice, it is high priority. We are not letting that go to voicemail. We make sure we respond to that. Super duper important to have that Judy call processed effectively. Now, let's make sure we show our appreciation. Let's say thank you if our patient does pay. And goodness gracious, saying thank you in general is just a great idea. So, not this, thanks so much for getting sick, but we appreciate your choosing us. And I think what that does is really important. Again, we've been talking about nomenclature and signage, but what we're doing is really conveying to our patients that they did have a choice, and we so appreciate that they chose us. What I hope we have done in our webinar today is to give you at least 3 ideas. Now, believe you me, I'm the first to know that one of those ideas won't work, and probably you'll get some eye rolling from the second one. But if we try one, or hopefully 3, but one sticks of those 27 ideas, and maybe even do them per quarter, we will see success. Well, I hope that our webinar gave you those great ideas. And I like to go in and turn it back over to Robert for our Q&A session.
Well, thank you so much, Elizabeth. Let's jump in here, and just want to remind the audience we still have time to take your questions, and you're welcome to submit those in the question chat box off to the right. So first question, Elizabeth, when should we send accounts to a collection agency?
Well, I believe this really has a lot to do with resources. And so, if we have enough staff resources within our billing office, then it's a great idea to go ahead and have that internal kind of collection agency, at least for, like, I don't know, 15 or 30 days. So I use that idea of that invitation letter, you can just use a collection letter. But I do like the kind of odd envelope and the address, the acronym, and the real stamp, just to make it distinguished. Now, if you say, Elizabeth, we do not have any resources to spare, then what you may want to think about is going ahead and using that agency. And probably, Robert, I would say to our audience member at about 90 days, and maybe wait that extra 15 or 30, but no more than 120 days.
Okay, well, our CPA advisors are going to be happy to hear that, Elizabeth. So next question is, what should you do if a staff member has worked at the front office for 20 years and has never really wanted to collect money?
That is a big pain point for a lot of practices. I think that, it's important, kind of stepping back, for our new team members is to make sure that that is included as one of the skills that we are looking for, at least part of those expectations. But for that employee who's never wanted to do this, the if not, why not report is a good little, just an extra touch. We want to make sure even that team member has been there for 20 years, that we go ahead and do that training that we talked about with how to ask. And I even like to put a little mirror. In fact, I have one on my computer, like just that reminder about how important when I present it is to use my hands, even if I don't have my camera on, how important it is to smile. So that mirror can be a really nice touch as well as a reminder. But please, another great idea is to actually use other businesses. How do, when we walk into, J. Crew or the Gap and we're buying a sweater, like how do people convince us to pay? So maybe even thinking about at a staff meeting, kind of talking about different ways that we see that's happening in other areas and other aspects of our life, and how we can bring that in naturally to the practice so it doesn't feel like I'm doing something bad. In fact, I'm doing something exactly that I see in other areas of my shopping experience, if you will. Robert?
Okay, great. Thanks so much. Here's a question that just came in, and it's regarding consent to treatment. How often should it be signed? Yearly, every 2 years, every 3 years? What's your guidance on that?
Well, consent to treat is definitely something we want to make sure that we have an attorney who is um, um, conveying that accurately, because interestingly enough, consent is at the state level. And so there's lots of different, really, I'll use the term great rules, but there are rules to make sure we abide by. So I'm going to have to defer that to one of our awesome attorneys who sponsored today's webinar.
Okay, great. Good advice. Next question is regarding the go paperless demand for $20. If paperless is declined, is a charge like this allowed for Medicare or other patients where electronic communications may be a barrier or challenge?
It's a great question. So some of this is you can waive that fee and not charge it. So it's kind of more of a nudge, right? There's some really interesting material. There's a great book called Nudge that I would really, it's all about behavioral economics and how to nudge people in certain directions. So one effort is you can basically say you're going to do it and then don't. But the second thing is it's very much like no-show fees. So when we charge a no-show fee, it's kind of the same thing. It's basically an administrative fee to cover our cost of, in that case, the patient not arriving. So we have an administrative burden associated with that. So the practices that I have seen that actually do it, they cluster that with their no-show fee. So they kind of consider that one and the same in terms of that administrative burden charge. Now, that being said, want to make sure that anytime we charge the patient outside of the allowable, that we check our contracts to make sure it's not disallowed. If it isn't and you want to clarify it, that contract negotiation would be a good part to actually integrate it. And again, I would marry that with my no-show fee because it's a lot the same. And then, of course, I'll go ahead and put in another plug to make sure we touch base with an attorney. about charging those extra fees. Robert?
Yeah, so this next question is about texting. Of course, we're all doing more texting these days, but should we text our patients regarding their balances?
I strongly advise that. I think it's a great idea. I mean, I don't know about you, but I remember getting my teenage kids cell phones and thinking they were going to call me all the time. It was the greatest thing ever. They don't even know how to use the phone part of it. It's like it's basically a texting device. So when we think about preparing for Gen Z, for example, who are now full force in our workforce, and now they're a lot of our patients, we have to have a communication strategy that includes texting. And so when we talk about appointment confirmations, which I like to use that term, versus reminders, because we're really asking the patient, like, let's confirm that you're going to be here. I'm not just reminding you, but I'm confirming this appointment. Again, it's a little bit of verbiage, but an important nuance. And then great opportunity. In fact, there are wonderful vendors who even completely automate the text to pay process, so that there's no manual intervention at all. So yes, 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 texting.
Okay, well, Elizabeth, that looks like we've addressed all of our questions. And I just want to say thank you so much, and a big thank you to everyone for joining us today. We hope that you found today's presentation educational, and we want to invite you to our next webinar coming up on November 9th. And in that session, our Jones Roth Healthcare advisors will discuss potential tax policy changes. We know they're coming, and how your practice can best be prepared. You can register for that webinar at jrcpa.com/healthcare. Well, that's it. Thanks again for joining us, and everyone have a great weekend.